proceed with caution. Age is kind of a soft consideration, but something you should be aware of. Performance status, the comorbidities, and their understanding of their current situation, kind of what cytoreduction HIPEC is and what it will achieve for them. And so that's what Dr. Fournier was talking about earlier about having those discussions ahead of time with the patient about expectations.
And they all pretty much come in thinking that HIPEC is this magic wand that's going to fix everything, and you just got to be very clear to them what you can expect to gain by doing this, because it's a pretty morbid operation with a long recovery back to baseline.
And so post-operatively, it's not uncommon for patients to have low-grade fevers within the first week or so. They are all going to have electrolyte abnormalities. What's your press? Oh, and so that's especially in the first couple of days. That's something you really have to pay attention to because they will have some severe electrolyte derangements. Um, for especially for oxaliplatin, they're gonna have these are very nephrotoxic agents, and so even though that they are making good urine, they will diurese, and so their urine output has to be exceptionally high, and you have to keep them very well hydrated, just because 30 cc's an hour is not adequate for these patients. Um, and so they're all going to have an ileus, or a lot of them will, almost without exception. High median number of stools per day, so they'll have some diarrhea, and then you know usually around the first, especially with mitomycin C, you can get this profound neutropenia, and you can also get thrombocytopenia and just pancytopenias. So what can the patient expect? The operation really kind of varies in duration, obviously, but it's about it's a long operation. There there is a significant it is a morbid operation, so there are complications. It does Patients tend to stay a little longer in the hospital than kind of most of our ERAS patients on other services. There's no ERAS for HIPEC. Yeah. Um, and then there is this kind of there's a dip in their quality of life and their functional status, and they will require serial surveillance every 4 to 6 months for the foreseeable future. And so question, 60-year-old female with low-grade mucinous penicillial neoplasm is offered cytoreduction hyperthermic or HIPEC. She states she has read about early postoperative intraperitoneal chemotherapy. Which of the following statements is true when comparing HIPEC to EPIC? So A, both therapies utilize heat. B, both therapies are administered in the operating room. C, both therapies can result in neutropenia. D, both therapies have level 1 data to show benefit for their use. Or E, both therapies take the same amount of time for administration and completion of treatment.
C.
Yeah, so they can both give you neutropenia. So HIPEC-induced complications, like I mentioned, the pancytopenia. Something I didn't mention was that they can definitely have poor wound healing, so we'll often leave staples a lot longer. We're a lot more careful about essentially wound healing in general. And then I mentioned the renal insufficiency, which is a big concern. Next question: a 40-year-old, otherwise healthy man has a symptomatic right inguinal hernia. He has a history of increased abdominal girth and early satiety over the past 12 months. The patient's weight is stable and he demonstrates excellent exercise tolerance. Upper and lower endoscopies are normal. CT of the abdomen and pelvis demonstrated a large appendix and ascites. Percutaneous biopsies indicate abundant mucin and scant cellularity. Which of the following is the most appropriate next step? A, open peritoneal biopsy with mesh repair. B, percutaneous drainage of ascites and right colectomy. C, repair of inguinal hernia with mesh and repeat CT in 6 months. Or D, exploration with histologic confirmation followed by cytoreduction and intraperitoneal chemotherapy. Or E, 6 months of systemic chemotherapy with those agents. FOLFOX and biologic agent and repeat CT. Right.
listen, so you laugh and you make that statement, but several times a year, someone comes in with that exact thing. And then they get mesh all stuck in, there's mucin all stuck in the mesh. It's unbelievable what happens out. It's unbelievable.
They'll usually just present with a hernia without a scan, and they'll go in and do the hernia.
Yeah, yeah. And then,
So
of
you
course,
just
like, I got the
still-
hernia. So, oh, my doctor got the hernia done, but he found out, he found out this thing, and they're all pleased that he did the hernia. And it's just crazy. I mean, it's just totally, it's crazy.
Would you ever consider saddle reduction without HIPEC, or is there an
Yeah,
indication when
yeah.
you do that? Or, like,
Sometimes you do.
It seems like people do that, but I don't really know what the indications for one.
So
both.
for appendix cancer, I would generally, certainly for low grade, I would generally use HIPEC. That definitely seems to help because the HIPEC part of this procedure really seems to control the ascites. Even if you can't get all of the disease out, it really controls the ascites. So I think as a general rule, I would do HIPEC. Now, if you have somebody who has some liver disease or hepatitis, so I've had a couple patients with Hep C and things like that. This was kind of sort of before treatment for hepatitis C, but I would not do the hyperthermic part. I do normal thermic perfusion because patients seem to tolerate that better, and you don't have so much toxicity related to the liver.
I was thinking more just not doing any type of intraperitoneal therapy.
Yeah, so generally not for low grade appendix. For other types, so for colon, you'll get to that if we have time. For colon, often we'll do that. Yeah.
Sorry, I didn't know you were talking.
No, that's cool.
I thought I saw a blank side.
Yeah, so I'm gonna try to cover this in the next 5 minutes. So for low grade appendiceal mucinous neoplasms with peritoneal disease, that's an indication. As you can see, there's a high risk of peritoneal dissemination in T3, T4, and then these patients are generally followed. So best available data for low grade appendix cancer. So this is data from this institution. 55 patients received cytoreductive surgery alone. And you can see their 5-year survival there. And then with cytoreductive surgery and HIPEC, you can see vast improvement. So definitely for low-grade appendiceal cancer. I'll skip the question.
No, don't rush, Jeff.
All right.
You guys started late. Everybody's an adult. You guys
Okay.
can leave if you want to leave. It's fine.
All right.
Everybody's
All right, so no one saw the answer. A cytoreduction in hyperthermic intraperitoneal chemotherapy perfusion has just been performed on a woman with an appendiceal mucinous neoplasm and pseudomyxoma peritonei. Despite a considerable disease burden, a resection is performed with a complete cytoreduction score of 0. The final pathologic evaluation indicates a low-grade mucinous neoplasm with 20 negative lymph nodes in the right hemicolectomy specimen. The patient recovers well after the operation, goes home in 3 days. Which of the following is the most appropriate follow-up care for this patient? And the answer is, yeah, a surveillance.
Just to highlight the important thing about that is, again, no chemotherapy. Low-grade adenocarcinoma of the appendix is a surgical disease. Surgical disease. Surgical disease. We see all the time patients are coming in, they got chemotherapy for 6 months, 12 months, 2 years. Doc, I've been on chemo for 2 years and I'm doing great. Cancer's not progressing. Yeah, no shit, because you didn't need it. we have a trial, open randomized controlled trial for patients who are not surgical candidates or who just refuse surgery, comparing so best systemic chemotherapy to nothing, and they actually they get 6 months of chemo and 6 months of internal control. We haven't accrued many patients, as you might understand, because it's a surgical disease, but we've seen no benefit at all.
So my apologies for this, but this is essentially the algorithm, our algorithm for treating patients with well-differentiated low-grade mucinous adenocarcinoma of the appendix. So the first is, you do essentially the staging and the review. If there's no residual disease after a appendectomy with essentially margin negative, no residual disease, imaging is normal, tumor markers are normal, and the colonoscopy is normal, then you just simply follow them. Essentially every 6 months for 2 years with tumor markers and imaging. And if the tumor markers and imaging after 2 years, no evidence of recurrent disease, then you can just go annually after that. Then if there's margin positive or there are elevated tumor markers, then you can do a diagnostic laparoscopy. If there's no peritoneal disease, you do a right colectomy if the margins are positive, and then kind of get back onto this track. If there's a biopsy-proven peritoneal disease and or a large volume of peritoneal mucin, then you assess for cytoreductive surgery in HIPEC. Um, and then on this over here, if there's known peritoneal dissemination, then you assess them for HIPEC.
Jeff, real quick. Did I just hear you? I can't.
Yeah, no, it's there. Sorry.
No, it's okay. Did I just hear you say that elevated tumor markers, negative laparoscopy, right hemicolectomy?
I'm sorry for.
Is that what I just heard?
No, so these are elevated tumor markers, diagnostic laparoscopy. If there's no peritoneal disease, then you do the right colectomy. If the margins were positive on the initial.
Oh, I didn't hear the
appendix.
margin.
Yep.
Yeah. I heard it was just.
No,
only
yeah,
elevated
just
tumor markers. I was
no,
like,
yeah,
But
margin
you'll
coverage.
do an ileocephectomy for those people, right? You don't do right colectomies.
No, just clear the disease,
Yeah,
right?
you
Clear
just
the
get a
disease.
negative margin.
Negative margins on
Your tumor markers are CA, CA19-9, 125.
Mhm. All right. A 50-year-old woman has surgical exploration for presumed ovarian cancer. Findings include tumor arising from the cecum, involving the right ovary, right pelvic sidewall, uterus, subdiaphragmatic peritoneal surfaces, and extensive small bowel serosal surfaces. There is no evidence of obstruction or bleeding. Evaluation of frozen section specimen from a peritoneal implant indicates high-grade adenocarcinoma with signet ring features. The patient has an excellent performance status and noted before the surgery that she wants you to do everything. She wants everything aggressive. What's the next step in the treatment? A. Administer HIPEC, limited cytoreduction to minimize morbidity. Administer HIPEC with complete cytoreduction. Perform cecectomy. Stop the operation. Refer the patient for whole abdomen radiation therapy. Or stop the operation and refer the patient for systemic chemotherapy. Yeah. So this is bad news. Stop the operation. Refer for systemic chemotherapy. So moderate and high grade appendix cancer, like I just mentioned, it's bad news compared to low grade disease. So at MD Anderson, the patient selection criteria for moderate and high grade for proceeding with HIPEC in patients with this type of disease, they can't be old and frail. Their PCI has to be manageable. There's mandatory diagnostic laparoscopy to evaluate that. Disease, so they have to be on systemic chemotherapy, and there has to be stability of disease, or they can't be progression of disease. There's got to be no extra-abdominal disease, no lymph node involvement, and no need for extended liver resections. And also, you can't have someone that you're going to leave with potentially short gut or significant bowel involvement. So generally, kind of patients who have low level of disease and have been stable or have a good response to chemotherapy and have good performance status and are young. Again, apologies, but this is the algorithm here, essentially saying the same thing. So the outcomes for CRS HIPEC for appendiceal primaries. So, overall survival is pretty good in all these series. Morbidity is kind of probably what you'd expect, and the vast majority of these have a pretty good cytoreduction. Question: a 60-year-old woman has cytoreduction for all macroscopic tumor of a mucinous adenocarcinoma with extensive involvement of the peritoneal surface, and HIPEC with mitomycin C administered by open technique. Which of the following represents the most common postoperative complication associated with the surgery? What's the most common? A. Prolonged ileus with or without evidence of pancreatitis, renal insufficiency that could be prevented with sodium thiosulfate administration, renal insufficiency due to hyperthermia that is self-limited and reverses on its own after 24 to 36 hours, intraoperative hyperglycemia, and severe electrolyte imbalances due to mitomycin C diluent, or temporary decreased WBC from chemotherapy-induced bone marrow suppression. Anybody? Yeah, so I mean, like I mentioned, they will all have an ileus post-op.
So
So
like the sodium thiosulfate, that's for cisplatin, right?
uh, for
Yeah,
the platinum
that's
agents.
you give that for people who get hypec with cisplatin for gastric correct?
How comes the decrease in the white blood cell?
So they all get myelosuppression. So they especially with mitomycin C, so they'll about a week out you can see a dip in their white blood cell count.
So all of them.
Almost, yeah. You can get it with all of them, but especially with mitomycin C.
But probably around 10% need something done about it. So, to give them magnesium or something like that.
So what do they get? They get ileus, like I mentioned, wound complications. So if you do the diaphragmatic stripping, you will almost undoubtedly get a pleural effusion, and that's why here we put chest tubes on the side. They'll get neutropenia, renal insufficiency. Um, you always worry about anastomotic leaks or abscess, pancreatic leaks, and then need for take back. So this is
Just highlight our mortality is 0.8%, not 0.5% common.
What's that?
Our mortality is 0.8%.
Yeah, and that's point zero, point oh four. I'm sorry. Point oh four.
Once you're here for a little while, you'll be able to see these numbers for every service. Exactly the same.
so so I think one of the major points of the talk should be that this is a morbid procedure, and there has to be good preoperative counseling. So this is a study looking at kind of functional status. Am I getting more already? Okay. Uh, so it's basically what this says is that they'll have a dip in their functional status. They'll feel like crap for about 3 months, and then they'll kind of recover to baseline. But that is part of the patient education preoperatively, is that they are going to have this dip in their overall baseline functional status.
The important thing about that is to actually highlight that preoperatively, that it will take them 6 to 12 months to get back to baseline, because invariably every patient thinks they're gonna be Superman out of the hospital in 5 days, and that they're gonna be back doing everything they want to do in 3 weeks. Every patient thinks that, so you just got to reiterate it multiple times to make sure that they truly, or do your best you can to make sure they truly understand that fact.
I think the other thing that you always highlight is the rate of complication, and that 50% of people are going to have
Yep.
some sort of complication, and people hear that, right? And so it's not like a surprise to your patients
Yep.
when they're in the hospital for 10 to 14 days.
You just, this is not an operation that you oversell in any way. Not that you should ever oversell any operation, but you got to be super honest and upfront about exactly what's going to happen to these people, because it happens to every one of them.
So as with any kind of major technically challenging operation, that there's going to be a learning curve, and certainly this series illustrates that there's improved survival after 130 cases, that there's also decreased complications after doing a fair number of these, and so there is this built-in institutional learning curve. 60-year-old woman undergoes cytoreduction in HIPEC for peritoneal carcinomatosis from colorectal cancer. She had colon and small bowel resections with anastomosis, peritoneal stripping of the right diaphragm, omentectomy, splenectomy, and bilateral salpingo-oophorectomy. Which complication is least likely? Pleural effusion, post-op bleeding requiring reoperation, prolonged ileus, pancreas fistula, or anastomotic leak? Yeah. So everything else is likely. This is the less likely.
The one reason they put that, I would just tell you, the reason why they put that here is they may think that some people have a little bit of familiarity. In Europe, where they use oxaliplatin doses of 400 milligrams per meter squared, we use 200 milligrams per meter squared. One of their common complications is hemoperitoneum. So I think that's where this question comes from. It's known side effect of high doses of
Just like
oxaliplatin.
burning blood vessels.
Not sure why exactly it happens.
Is it like post-operative HIPEC, but it's hypothermic bleeding? It just like
Run back to the negative.
Yeah. Now we're gonna bathe you inside of the blood.
So for colon cancer, so this this is kind of one of the major findings at SSO this year was kind of how this relates to colon cancer. So it's a significant burden of disease. About 13% of these patients will develop peritoneal metastases, and HIPEC has been proposed as an effective strategy. But when we talk about this, we do have to put in the context of kind of more contemporary chemotherapy. Colon cancer obviously has been treated for a long time, and the chemotherapies have changed quite a bit, and essentially survival now is much better with our current agents than they were even kind of in the more recent past. But when you look at peritoneal carcinomatosis, the prognosis is pretty poor. You can see here that the overall survival is much worse with peritoneal disease. And also, what's really interesting is that peritoneal disease is different. So essentially the molecular and genetic profiles of these tumors tend to be different than what you would see in, for example, hepatic metastases. Why is there a resistance to systemic chemotherapy? Well, these peritoneal nodules tend to be small and are generally poorly perfused. They have elevated interstitial fluid pressure, and they're a hypoxic tumor environment. So when you compare cytoreductive surgery HIPEC versus systemic chemotherapy, there is some benefit to the CRS HIPEC versus systemic chemotherapy. How much of that is the CRS and versus the HIPEC, we'll see in just a second. But then there's also this series where they had 48 patients who received systemic chemotherapy that were actually candidates for the cytoreductive surgery in HIPEC, but for whatever reason, logistical reasons, they prevented from having that. And again, you can see that HIPEC and cytoreduction had improved survival. Skip that. So here's our data from MD Anderson using CRS HIPEC for colorectal cancer. 52 consecutive patients with colon cancer and peritoneal dissemination of disease who underwent CRS and HIPEC. Used oxaliplatin for 60 minutes and looked at disease-specific survival and saw that overall it's about 55 months. And then a lot of it, you can see here that if you get good cytoreduction, it's a lot better than if you don't. And also if you have high grade versus moderate grade, that also makes a difference. Which leads us to the Prodigy 7 trial, which is a multi-center randomized phase 3 trial comparing cytoreduction alone to cytoreduction for HIPEC and HIPEC for colorectal peritoneal carcinomatosis. So they randomized 1-to-1. They stratified by center. They had 17 different centers. They also stratified by completeness of resection and neoadjuvant therapy. And then the primary endpoint was overall survival, and secondary endpoints were what is it, RFS? Help me out. There we go. Sorry, blanked, and toxicity. So they had 265 patients. The arms were equal. The median age was 60. It was pretty well balanced. So the take-home points are there's no difference in overall post-op mortality. There's no difference in morbidity at 30 days. The higher grade, there was higher grade 3-5 morbidity in HIPEC at 60 days. And then after a median of 64 months, the overall survival was essentially the same. And the median recurrence-free survival was 11.1 months for those without HIPEC versus 13.1 months with HIPEC. So really not much different and a little more morbid to receive the HIPEC. And so here you can see the survival curves essentially kind of traced over each other. The median survival the same. And then when you do the subset analysis, though, you can see that there are some patients that do benefit from the HIPEC. You can see that over here, the patients with the PCI 11 to 15 seem to have a better survival when you perform the HIPEC or not, versus people that didn't, and that kind of makes sense. You know, if you have disease that is terrible, you know, I don't think probably no matter what you do, it's going to be bad. So the outcome is not going to be any different. And then if you have disease that's very small amount of disease, and you essentially do the cytoreduction, you're going to do well, kind of regardless. But there's this middle, you know, essentially block of people who have, you know, moderate disease that you cytoreduce, and then you clean up what's left with the chemotherapy, and there may be a difference, or it looks like there is a difference for those patients. So for those patients that have colorectal cancer, peritoneal carcinomatosis, I think there's certainly an argument that you could offer HIPEC for those patients.
So I want to ask you something about this, and maybe this is what you were going to get at, but I've heard you say to people, like, your quality of life is affected for 6 months, reduced for 6 months. That's a 9-month difference in survival. So are you, or are we as an institution, right, is this something that we're still going to pursue?
So right now we're doing that 11 to 15 range only. So we do, and part of it has to do with our outcomes, right? Our own institutional outcomes is better than this by a fair amount, actually. Our overall survival is more than 60 months, right? And so I feel okay making the case to do it, but I don't do it for low volume disease. And it makes sense, right? You think low volume disease is truly just a local failure, probably, right? And then high volume disease is just a failure of everything. They're not going to do well no matter what you do. But that mid-range is kind of maybe a field defect in some way, that some of the peritoneal cavity is involved, and it makes sense to consider doing this. Some other important points about this, though, actually, is that we're on these email chains of people who do all of this, and you should, everyone was in an uproar about this because we were saying, you know, some of us were saying we shouldn't be doing it and all of this, and people just kind of freaked out about it. But it does highlight a couple of things. Number one is maybe oxaliplatin isn't the right drug. Maybe the time, because we don't know the interval they use. I mean, the length of HIPEC they use 30 minutes, right? Versus 60 versus 90 versus 120. Doses. I mean, there's a lot of things that kind of go into this. But it could just be that it doesn't work. It just could be that it doesn't work. Another important point of this is that, you know, we've often thought about trying to find patients who are at highest risk of failure, and could prophylactic HIPEC be beneficial. This probably suggests that it is not beneficial, right? So somebody who has a woman who has ovarian metastasis at the time of her colon surgery, you take out the colon and the ovarian metastasis, she's considered high risk. But this data would suggest that HIPEC is not going to be helpful for prophylaxis. There's a number of trials open right now. There's at least 3 trials that are looking at this. But I strongly suspect that we'll find that it really probably doesn't work.
Are you basing the decision on radiographic PCI or surgical PCI?
Surgical PCI.
Okay.
So when I talk to the patients, I tell them if it's low volume, you get no HIPEC. If it's, you know, moderate, you do it. Usually, I do a laparoscopy on every patient before I do HIPEC, so I have a, you know, very good understanding of what their disease burden is. It's rare that we change from the time I do my laparoscopy to the time I do surgery.
So another indication for HIPEC is peritoneal mesothelioma. This is an extremely rare disease, but yeah, I think probably most of us have seen at least one case in on our rotation with you. So the rare disease is not so rare here. So there is a link to asbestos exposure. There's a latency period, just like in pulmonary. There seems to be a closer relationship with males in terms of asbestos exposure. And this is one of the diseases where kind of the subtype really matters. So for the sarcomatoid, it's just bad. They just go to systemic chemo, and the outcomes are not good. biphasic. It's essentially kind of a case by case, and then really the favorable ones are the epithelioid, and the really favorable one is the papillary. And you can see the best available data for mesothelioma with just traditional therapy, not so good. And then with CRS and HIPEC, it's better. It's pretty good. You know, there is kind of an overrepresentation here of some of the kind of more favorable subtypes.
So just to tell you that, so this is our data rag over here. So all, for the 78 months, that's epithelioid for all comers with, you know, epithelioid, some with papillary, etc., was 201 months. So it's
Definitely,
definitely,
yeah.
definitely.
And then I think this was mentioned earlier. You know, you can also use it as a palliation for ascites. I think you know once you see someone who's like a redo HIPEC, you can definitely see kind of you know one of the things that this therapy does is it definitely kind of locks things in place. Like there's a lot of scar formation, a lot of adhesions that are formed, and it seems to really kind of dry up the milieu within the peritoneum, and that's one of the benefits, especially with these tumors that create a lot of ascites. This is another paper just showing kind of the positive prognostic factors. These are from Australia. And then here's our algorithm for managing mesothelioma, peritoneal mesothelioma. And really, it's just kind of what we talked about already. It really depends on the subtype and whether they're, you know, if they're really favorable subtype, you know, you can move to cytoreduction and HIPEC. If they're a bad subtype, really just go to chemotherapy and see what the response is, and then can consider later. And then the kind of the middle of the road subtype, it kind of depends on the burden of disease, whether you proceed with HIPEC.
And we just sort of changed it. Previously, for patients who were coming in with potentially resectable disease, epithelioid subtype, we were doing CRS and HIPEC kind of up front. And over the last year, we've kind of changed that a little bit, trying to identify patients who may benefit more from neoadjuvant approach. So we're using the CT-PCI. So I can't give you any good data on that yet. Hopefully within the next year we'll have some data on that.
And then some more outcomes after, this is for repeat cytoreductive surgery and HIPEC for mesothelioma. You know, when you can still, you know, some of these series, you can still get a pretty good cytoreduction, and the overall survival is still decent for repeat operations. So, you know, what are the accepted indications for HIPEC? Definitely for appendix. Mesothelioma, certainly the more favorable subtypes. And then for colon carcinomatosis, I should have actually modified this. This really is for PCI 11 to 15 now. Roland sarcoma, I think you're going to see a lot of this in the literature. There has been data here in the last year or so that seems to suggest that there is not, especially for desmoplastic round cell. The role in gastric cancer is currently being studied here as well, and there's some emerging data for its use in ovarian cancer as well. And so, conclusion, you know, pathology. The pathology is a big determinant. The impact of cytoreduction is also important. The higher the grade of the tumor, the more important the PCI. And then the impact of the package of cytoreductive surgery and HIPEC is, well, at the time before, at the time before the Prodigy 7 wasn't entirely clear for colon cancer, but it's now becoming more clear. So last question, 55-year-old man has laparoscopic appendectomy for acute appendicitis. During the operation, a contained rupture of the tip of the appendix is found. Gelatinous ascites fluid is evacuated from the abdomen pelvis. Pathological evaluation indicates a 3-centimeter low-grade mucinous neoplasm obstructing the lumen of the base of the appendix with perforation of the tip. All margins of the resection are negative, and there is no invasion of the mesoappendix. Cytologic analysis of the mucinous fluid demonstrates extensive acellular mucin with scant low-grade mucinous cells. Which of the following statement about this type of neoplasm is correct? A. Epithelial neoplasms of the appendix are found incidentally in 1 to 5% of appendectomy specimens. A right hemiplectomy should have been performed at the time of surgery. Cytoreductive surgery and HIPEC should be considered for this patient, or cytoreductive surgery and HIPEC are associated with morbidity rates less than 10% in the setting. And at least according to SOSAP, this was the best answer. All right, let's. Yeah, I guess one of the big questions is also, I think Dr. Fournier brought this up, is, the agents. So if you think about it, a lot of the agents that are currently being used in HIPEC are agents that have presumably failed systemically. And so, one of the big questions that I think we're trying to answer now is, well, why use these same agents and what new agents can we use? And so a lot of the current efforts are really to try and have preclinical and eventually clinical data support the use of immunotherapies as a use of in with direct peritoneal administration. So that's something that we're looking into doing. Any other questions? All right, sorry to keep you guys over.
I feel sorry. I thought you were on call.
Oh no, it's my fault. It was on the.
I tried really hard to block this conversation.
Sorry, no worries, man.
Incidental radiologic finding of gallbladder high drops with no symptoms, but the patient is really anxious about it.
Oh, okay. Did you have one today?
No, today was APR.
Oh,
I was like, I was like,